Good evening, everyone. I am Julia Mobley, ArcScan's Marketing Manager and your host this evening. And I'd like to welcome Dr. Brett Mueller with Parkhurst NuVision as our presenter. Dr. Brett Mueller is a board-certified refractive, cataract, and anterior segment surgeon at Parkhurst NuVision, and ArcScan is very excited to have him here. Please feel free to type any questions you may have throughout the presentation in the Q&A section of this webinar, and then Dr. Mueller will be answering those after the presentation. So without any further ado, here is Dr. Mueller.
Good evening, everybody. My name is Brett Mueller, and I'm an ophthalmologist down in San Antonio, Texas at Parkhurst NuVision. What I hope to kind of speak with you guys today is in regards to the ArcScan and how it has really revolutionized the way that we do ICL sizing in our practice, and really has been a game changer for us. You know, when people are talking about ICLs, and anyone who is an ICL surgeon, we know that the most difficult and challenging aspect of the surgical procedure is not really the surgical procedure itself. What it is the sizing. The sizing is the most challenging part. And with the rudimentary way that we normally are taught to do it by using white-to-white measurements, it's an okay method, but it really does not do the job well enough. And then with the other methods of using ultrasound, where you use like a UBM and get sulcus to sulcus measurements, those are also pretty good. But even in those instances, we do get those outliers, those patients where, you know, a couple times a year, maybe they come in and the vault is too high and now they're in angle closure. And so now we're having to deal with that sort of surgical emergency, essentially. Or, you know, perhaps we have an ICL with the vault size is too small. And in that case, now we're dealing with, well, do we have to explant this or do we just monitor them? The risks of getting cataract formation, all of those sorts of things. What I hope to impress upon you today and with this talk is that how the ArcScan has really helped us eliminate those outliers. And then ever since we've been utilizing this technology, that we have not been able, or we have not had any vault sizes that have been too big or vault sizes that have been too small. And so I'm going to go through that data with you right now. So when we look at this, the first study that I'll kind of want to go through, and this is a study that I did a couple years ago, and it was basically looking at the toric ICLs and basically looking at it as a refractive option of treating myopic astigmatism. And what we did is we looked at this as a retrospective study looking at the clinical outcomes of 143 implantable toric ICLs that were done at a single surgical site. This retrospective study evaluated 143 eyes of 75 patients, and what we did was we looked at pre- and post-operative uncorrected visual acuity and best corrected visual acuity. We also looked at pre-operative and post-operative mean refractive spherical equivalent and astigmatism magnitude. And then we also analyzed a subset of patients that were unable to see 20/20 pre-operatively and see what did they get a visual acuity benefits after the procedure, and compared that pre-operatively and post-operatively. Now, in this data, what we did is, you know, when we looked at this 143 eyes, when we looked at the mean spherical equivalent on a Logmar scale, is about uncorrected was 1.37, and on average, most of our patients are seeing about 20/20 post-operatively. When we look at the corrected distance visual acuity and compare that to pre-operatively and post-operatively, we demonstrate that our patients are actually seeing better after the ICL procedure, better than they've ever seen before. Our mean spherical equivalent, we're doing pretty well with being at about a quarter of a diopter, and then our mean astigmatism magnitude is at about 0.79. Now, when we look at those eyes that were unable to see 20/20, and there were about 31 patients, so for whatever reason, if they had amblyopia or if they had some irregular stigmatism or keratoconus or something that did not allow them to be able to see 20/20 preoperatively. When we look at these patients after they got to the procedure, and on average their corrected distance visual acuity on a Logmore scale was 0.23, we saw that these patients improved to be able to about 2 lines of vision that were able to see 20/20, if not better. And then, of course, when looking at this at the mean residual spherical equivalent, these patients were able, they were about, minus 1.1, plus or minus 1.9, and then the astigmatism magnitude was about 1 diopter as well. Just showing the benefit and how incredible this technology is of these ICLs and how they're really able to provide a very good refractive solution for patients. When we look at the scatter plot of these patients in the scattergram, looking at comparing, achieved spherical equivalent versus intended spherical equivalent, we're able to show that about 87% of our patients are able to get within a half a diopter or less of their intended spherical equivalent target. And look at the range of what we're trying to achieve here. I mean, we're talking patients that are going from -3 all the way up to about -17. So it's a pretty good, tight scatter plot that we have going on. So the ICL is an incredible technology and very predictable in terms of being able to achieve what it is that you want to be able to achieve refractively in patients. And then we demonstrated 12% of the eyes were within 0.5 and 1 diopter. And essentially, we only had 1% of eyes that were over 1 diopter. And of those eyes, those patients both of them had keratoconus. So it made it a little bit tricky for us to be able to do. But pretty much able to predictively achieve a 1 diopter or less spherical equivalent in patients utilizing the toric ICLs. When we looked at the complications associated with this study, when we looked at our toric ICL implantation, complication rate was essentially 0. So very good in terms of great technology showing great efficacy, but also great safety as well. So this begs the question, why are not more refractive surgeons utilizing this incredible technology? We just went through, it's just some crazy and incredible benefits of what, patients can get refractively from this. And so why are people utilizing this technology more and more? And the answer is sizing. I mean, sizing is the key to this whole thing. And with the analogy that we like to use is, if you're going to look at a house and if you want to see what a house is look like, if you're going to go buy a house, are you just going to drive by and look at the outside of the house and not really go inside to see what's going on? No, of course not. You're going to go inside the house to see what it looks like. You're going to go look at the bedrooms. You're going to go look at the bathrooms. You're going to go look at the kitchen. You're going to look the same thing. Why wouldn't we do the same thing for the eye when we're going to be putting this implantable contact lens or implantable Collamer lens inside the eye? We need to know what the different sizes are, the sulcus to sulcus length, the ciliary body length, the angle measurements. We need to know all of these different things in order to be able to best pick the size that is going to go inside the ICL. And just using the external measurement of white to white is just not appropriate. Now, the way that we always utilized it down in San Antonio at Parkhurst NuVision is we never really subscribed to the white to white. But before the ArcScan, we used UBM, and the UBM that we used was the Sonomed. And our main goal and objective was to look at the sulcus to sulcus measurements, and then also look in the lens rise. And then essentially what we would utilize is the Parkhurst nomogram, which is shown here. And based upon what the sulcus to sulcus measurement was or what the lens rise was, we would then be able to pick, okay, are we going to pick a 12.1, a 12.6, a 13.2, or a 13.7? And this modality works pretty well in terms of being able to predict the correct size in most patients. But as I was saying, there are a few times per year where we would get either an overvault or an undervault in these patients, and especially in terms of the overvault, where you then get this of iris pushing up against the cornea, closed angle, patients coming in pain, nausea, vomiting, all these sorts of things going on. Really makes you second guess yourself in terms of, do we really want to be doing this procedure when we can potentially get this result? And it can really turn a lot of surgeons off. I mean, you get one episode like this in a young patient where you have somebody where you've thrown them into angle closure, it can really make you not want to do this procedure. And so that's why, we think that with this ArcScan and what we have seen, and I'm going to show you the data that we've seen in just a little bit, is that we are essentially able to eliminate those outliers to where now we don't have to worry about this. Imagine if we're able to do this procedure and we don't have to worry about there being undervault or overvault anymore. We've essentially eliminated the most difficult thing that is impeding surgeons from adopting this technology into their refractive practices. And then not to mention too, I mean, the UBM is just, it can be very challenging and difficult procedure to do, especially on patients. I mean, we've had some patients that have gone in full-blown anxiety attacks from this. We've had to give them Valium before. I mean, and it's really dependent upon the technicians and how good they are at acquiring these images too. I mean, it's not that easy to get very good and reproducible ultrasound measurements utilizing the SonoMed and the UBM. So then this leads us to the ArcScan. And what I first want to do is, before I start going into the data, is just demonstrate how easy it is for us to be able to obtain data utilizing the ArcScan. So this is a video, and this is one of our technicians getting measurements of their interior chambers utilizing the ArcScan. And as you can see here, he's kind of got his eye propped up against the ArcScan. And as you can see, he's looking in there and getting the measurements, and he looks very comfortable. It's not that difficult at all, and it's really not that technically challenging for technicians as well. I mean, I feel, at our facility, we have some of the best technicians out there. The technicians that we have are utterly amazing, and they can get very good UBM measurements, but look how easy this is in terms of just getting very good reproducible measurements of the anterior chamber, the ciliary body, the sulcus to sulcus links. I mean, it's just very good, incredible images, and it happens very quick as well. And so within 2-3 minutes, you can get very good, high quality images of both the right and then of the left eye. And here, this is an image. So how do you then utilize this technology to then get further information that you need? And so this video here is going to kind of go through my regimen of what I do to take 7 different measurements of being able to then plug that into the ICLsizing.com website to then be able to further predict what ICL vault size I'll have.
The ArcScan is really nice in being able for you to effectively and quickly be able to take 7 measurements that will help you to be able to better predict the ICL sizing that you're going to be putting in your patients. How I like to first start off is by first getting a ciliary body measurement here. I then go and get a measurement of the sulcus here. Just going along the iris pigment epithelium. I then like to go angle to angle here. I then take an angle measurement, like so, here. You then get an anterior chamber depth here. And then you can zoom in. This is going to help you to get the lens rise from the angle measurement. And then one last final lens rise from the sulcus. And that's it. Very quickly, within 1 or 2 minutes, you can get all 7 measurements that you're needing to be able to punch into the ICLsizing.com website. Thank you very much.
So as you can see, a technology that's very easy for patients to be able to go through, very easy for technicians in order to be able to get very good, high quality anterior segment images that we can then go and measure. And getting the measurements is very easy too. I mean, it can take me less than 1 or 2 minutes to get all the measurements that I need to then input into the ICLsizing.com website to then come up with the data that I need to be able to then pick which ICL vault size that I want, or ICL size that I want. So I'm gonna go through a study, and essentially, to date, determining the appropriate ICLs, and this is basically a study that we've done looking to see what the efficacy has been in our practice and how well has the ArcScan in combination with Dan Reinstein's ICLsizing.com been at predicting the ICL vault size. So, pretty much to date, the appropriate ICL vault size, 12.1, 12.6, 13.2, and 13.7, remains one of the most difficult challenging of ICL surgery that we've described. The current method utilized by surgeons is to obtain the white-to-white measurements and plug them into the OCOS online calculation ordering system, which will then recommend the certain size based upon the given white-to-white. And like I was mentioning, there are many factors that need to be considered, more so than just white-to-white, in order to be able to effectively predict which ICL size needs to be put in each individual patient. When we look at the ArcScan Insight utilizes very high-frequency ultrasound technology that enables surgeons to get reproducible and high-resolution intraocular images that can be utilized to more precisely and accurately pick the appropriate ICL size. And really, you're looking at 8 different measurements that you're going to be taking when you are doing this procedure. And those are going to be the anterior chamber depth, the anterior chamber angle, angle-to-angle measurements, anterior chamber width, measured scleral spur to scleral spur. You're going to get the angle recess to angle recess lens rise, sulcus to sulcus measurements, sulcus to sulcus lens rise, and ciliary body diameter. And this will be demonstrated here. You then need to take all this data and you then input it into the ICLsizing.com website. Again, this is through the London Vision Clinic, that's owned and operated by Dan Reinstein. And this is kind of like what it looks like here. So essentially, you input all of this data into this, and there are 11 different parameters that you are inputting for each eye. So, and there's white to white that's in there too, but there's a lot of other different data points that are in there as well. And then with this data, it then plugs out or puts out and says, okay, well, based upon these measurements, and then it will give some other formulas that have been out there too. The Doherty formula, that's one that we've kind of, it's a little bit similar to the Parkhurst formula, the Parkhurst nomogram that we use. And it will actually take and show you what the actual vault size would be. So like in this individual patient, what's pretty cool about it is that it can predict and say, okay, well, if I put in a 12.6 for like the right eye, for example, you could expect to have a ICL vault size of about 400 microns. And if you put in a 13.2, you could expect to have about 668 microns. And so it can really be utilized. And so like, which one would you pick in this particular case? And it depends. I mean, if I given an anterior chamber depth, like in this patient, of around 3.2, and the fact that, let's say if I was putting in a toric and I wouldn't want to have it to rotate or spin, I'd probably lean more towards a 13.2, and I would know, that I would be within that 250 and 750 micron safety zone of what we really like to achieve when we're looking at our vault size. But if I was putting in a sphere and I wasn't too concerned about rotation, I know that I could put in a 12.6 as well, and that the 12.6 would give me a vault size of 400 microns, and I know it wouldn't be too shallow. So that just shows like one of the beauties of this technology is it really can help you to customize each patient's own vault size to each of their eyes, and you can then pick and choose which ICL that you want to be able to do and really customize that vault size to each individual eye that you're going to be treating. So in our study, what we did is we retrospectively looked at our ICL patient cohort to assess the accuracy and predictability of using the ArcScan in conjunction with ICLsizing.com to predict the lens vault size. This study is going to have 160 eyes, and these results will show the first 100 eyes of those. And we looked at this, when we looked at the scatter plot size, on average, our vault size prediction was within 54.7 microns, which is pretty dang good. To be within 54.7 microns of what you're intending to predict in terms of vault is pretty incredible. And then when we look at in terms of accuracy and how good that we are in being able to predict within microns this vault size, about 97% we are able to get within 300 microns of our intended target, which is incredible. I mean, that's like a half a corneal thickness that we're able to achieve with this technology, which is just utterly incredible. So in conclusion, we have a 0% rate of ICL vault sizes so far utilizing this ArcScan of the vault size either being too small or too large, that we're able to predict within 300 microns 97% of the time. Are we within 300 microns 97% of the time of the ICL vault size? And that we really believe that this ArcScan is the future of being able to predict ICL sizing, and will be the future, and will be the gateway to more surgeons and more refractive surgeons adopting ICLs into their practice. Because once we can eliminate those outliers, once we can say, you know, we don't have to worry about the angle closure patients coming in the middle of the night, we don't have to worry about the cataract formations, that is going to instill more confidence in more surgeons, and that they are going to confidently be able to adopt this technology and be able to offer patients. So with that, I appreciate your time, and I will address any questions. Thank you very much.
Okay. Thank you, Dr. Mueller. I think we have a few questions if you're ready to answer those.
Sure.
Okay, looks like we have the first question. How does the Insight 100 compare to other anterior segment imaging devices?
Yeah, so I mean, in our practice, we have found that the ArcScan, just in terms of image quality, is just far superior than what we've seen with other anterior segment imaging devices. And also the reproducibility in terms of getting very nice images time after time, and really technician independent as well with the ArcScan Insight 100. And then also too, just the depth that you're able to obtain as well. You know, we're looking at the big key factor that a lot of people are finding, including, you know, Dan Reinstein and the Zaldivars, is basically identifying the importance of looking at the ciliary body to ciliary body inner diameter and utilizing that to determine what would be the appropriate ICL vault size. And this technology enables us to be able to view that beautifully.
Great. How often would you say that you use the Insight 100, and what would be the most frequent use for it?
For us in our practice, I mean, we're primarily like a high volume cataract refractive practice down in San Antonio, Texas. And our main reason for utilizing this technology is for ICL sizing. But we also use it too for epithelial thickness mapping as well. The epithelial thickness images that you can obtain from this technology is absolutely incredible too. So we'll utilize that for patients to see if they're a LASIK candidate, or if we would rather steer them more towards PRK as opposed to LASIK. But it's enabled us to utilize that as well. So.
And do you use it for anything that you hadn't originally anticipated it for?
Those are the main things. I mean, if we're having if we want to get just really good high resolution anterior segment images just for whatever reason. I mean, there's times where patients, they'll have like a corneal scar and want to see how deep the corneal scar is. So we utilize this technology to image the cornea and to see, okay, well, how thick does that scar go? Can we put a LASIK flap in there? Really much just anytime we want to get really good high resolution anterior segment images, that's when we utilize this device.
Okay, couple more questions we have. How does this technology compare with an anterior OCT, in your opinion?
Compared to an anterior segment OCT, I feel that, like I was saying before, is that the resolution that you're getting at utilizing with this technology is just superior. The images are better, higher quality, and then you can get down to that ciliary body measurements as well to measure that inner diameter of the ciliary body length.
And how do you use this technology post-operatively?
So post-operatively, so let's say if we want to see how an ICL is potentially, if it's if it's not sitting appropriately, or we want to look at the vault size, or if we want to get any high resolution details of what's going on in terms of how the ICL may be in the eye, we'll then utilize it for that purpose.
Okay. Next question. Any chance that the system would be able to do an automated 7 measurements instead of manual placing?
That would be awesome. And it would be awesome too, is if we could get those measurements automatically inputted into the ICLsizing.com website. Yes, I hear you. That would be a great add-on to this technology for sure. I would love to see that added. Absolutely.
Maybe in the future.
Maybe in the future. It doesn't do it now, but I would definitely love to see that.
Okay. After knowing this technology, would you implant an ICL without it?
Honestly, I would not feel confident putting an ICL in an eye without utilizing this technology. I mean, it provides so much information to me that I like to be able to have at my disposal in order to be able to know which vault. I mean, even in that one example that I presented, I mean, I think there are patients out there that could benefit from one size or another. And then there's an art to this ICL sizing. It's not like an exact science. And this just gives you just so much information that you're then able to use at your disposal. And so that you can then, fine tune and tailor each ICL vault size to each individual eye and each individual patient. It enables you to be able to do that. And so right now, since I've been using it, and I predominantly do most of the ICL sizing in our clinic for our practice, and I couldn't see myself not using it anymore. So.
Great. Okay, next question we have is, are the scans rebatable? How is your business model?
No, the scans are not. You can't. I mean, I'm using them for refractive images and stuff. So, patients come in. I mean, it's cash-based procedures and stuff that we're doing, and so we do this as a part of the amount of money that the patients came in and paid to get the procedure. So we're not trying to get insurance to pay for this.
Okay. Would you say that it was a fairly easy input into your clinic workflow as a new piece of technology that your technicians had to learn to use?
Absolutely. I mean, for the basically for the as you can see, the video that we showed, it was very easy for our technicians to learn how to do. I mean, there's really not much for them to do. I mean, they just kind of put the patient there and they line them up, and then the machine does the rest. I mean, it's pretty cool. Like, you don't have to worry about holding this like UBM probe and are you too close or not, or too far away. I mean, the machine really just kind of takes care of all that stuff for you. It's really simple to use and not that cumbersome.
And I know you talked about it a little bit during the presentation, but how would you describe the patient experience? I know you've had nervous patients using the handheld UBM, but compared to the Insight 100.
Yeah. So there's two things that we always tell patients that are the worst part about ICL procedure. One of them is the UBM, and the second one is the PI. And now I think with the ArcScan is we can take that UBM out, and I'm hopeful if STAAR in the very near future, once we get the EVO, we'll be able to now say no longer we need to be able to do the PI. So I think now with both the UBM and EVO, we can now say, you know what? Now we're just going to just fix that myopia and astigmatism that you have, and we don't have to worry about this this horrible UBM that we used to have to do way back when, or this PI procedure.
Great. Okay. Well, I don't think we have any more questions coming through, so I'll just end it with if you had to give doctors one key takeaway from this presentation, what would it be?
I mean, I just really think that, well, first off, I am an avid advocate for ICLs and the incredible technology that this can offer patients. I mean, my own sister has ICLs. In our practice, I think each of the doctors, either one of the doctors has ICLs in their eyes or one family member has it. So we love this technology, and we really want other refractive surgeons to adopt this, because I think if people hear more about it, they'll realize how incredible it is. And the way that we get this technology out there to more surgeons is to get them comfortable with the sizing. If they can feel comfortable and confident with the sizing, then more refractive surgeons will adopt it. And I could see, ICLs being probably one of the #1 refractive procedures done. I mean, it is an incredible technology. And if we can get better sizing, which we can do with this ArcScan, I think that's the way to do it. So.
Okay, great. Well, thank you so much for your time, and to everyone who participated, and have a great evening.
Thank you.
All right, thank you.